Good afternoon, and welcome to the HIV Health Improvement Affinity Group webinar entitled Increasing Rates of Virologic Suppression, Promising Practices from the HIV Health Improvement Affinity Group States. My name is Commander Kathleen Davis, and I will be your moderator for this afternoon. So our agenda for today is to hear a little bit from our federal partners about this exciting project that has been going on for the past year or so. And then we are going to move on to hearing from two of our states that participated in the Affinity Group and their lessons learned. And then we'll open up for some question and answer and some forthcoming resources. Some quick logistics. Your lines will be on mute for the duration of today's webinar. If you would like to ask a question, please use the chat box in the lower left-hand corner of your screen. And then we will hold all questions and comments from the chat box until the end at the Q&A period. But please go ahead and ask any questions throughout the webinar. And finally, please complete the evaluation in the pop-up box after the webinar to help us continue to improve your experience. Today, I am very happy to introduce four dynamic federal speakers. This has been a true partnership between HHS, CMS, HRSA, and CDC. I will read through quickly the bios for our four speakers. Our first speaker will be Dr. Rich Whalen. Dr. Whalen currently serves as the Director of the Office of HIV/AIDS and Infectious Disease Policy. Prior to this, he serves as the Associate Director for Program and Performance Improvement at the National Center for HIV, Viral Hepatitis, STD, and TB Prevention at the Centers for Disease Control and Prevention. Dr. Whalen has played key leadership roles in a number of groundbreaking studies, including Community Promise, Project START, the Seropositive Urban Men Study, and the Housing and Health Study. He's an associate editor for the AIDS Education and Prevention and serves on the editorial board of AIDS Care. Dr. Ellen Marie Whalen is the Chief Population Health Officer at CMS for the Center for Medicaid and CHIP Services and a Senior Advisor at the Center for Medicare and Medicaid Innovation, where she coordinates the pediatric portfolio across the center. Dr. Whalen holds a bachelor's degree from Georgetown University, a master's degree and PhD from the University of Pennsylvania, and the Leonard Davis Institute of Health Economics, and completed a postdoctoral fellowship in primary health care with Barbara Starfield, MD, at the Johns Hopkins School of Public Health. Heather Hawk is the Deputy Associate Administrator, HIV/AIDS Bureau, Health Resources and Services Administration, or HRSA, Department of Health and Human Services. The HIV/AIDS Bureau provides leadership and resources to assure access to and retention in high-quality integrated care and treatment services for vulnerable people living with HIV and their families. And finally, Dr. Janet Hikaru is a behavioral scientist at CDC. She is currently the Associate Chief for Science as well as the Acting Health Department Monitoring and Evaluation Team Lead in the Program Evaluation Branch, Division of HIV/AIDS Prevention, National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. I will now pass it off to Dr. Rich Whalen.
Great, thanks so much. I have to say it's truly a pleasure to be here with you today. It's been a great group of collaborators to work on from the federal side since the beginning, and I'm just so pleased to have heard about some of the progress that's been made, and I'm anxious to hear about what is coming out of the work and the experiences that the states have had over these past couple years. I mean, we truly believe that your work will be a model for your peers, for your colleagues in other states, and will really be a significant contributor towards moving us towards our national goals related to viral suppression and our vision of ending HIV in the U.S. I think, as all of you know, viral suppression is just so critically important to the health of people living with HIV. When people take antiretroviral medication as prescribed, almost everyone can achieve an undetectable viral load. And when that's achieved, it means that the progress of the virus has been halted. The disease is essentially no longer progressing, and what we've learned in studies over the past few years is that it also means that the person living with HIV, as long as they maintain that viral suppression, that there's essentially no risk that they can transmit the virus to others sexually. It's a tremendous breakthrough. It's a game changer. It really rewrites decades of messages and information that we have communicated repeatedly about what it means to be living with HIV. The evidence is clear that someone who's on HIV treatment and is virally suppressed has effectively no risk of transmitting the virus to others. Think about what that means. There's tremendous implications for how we approach HIV prevention in the U.S. When CDC has done modeling studies looking at this issue, they found that over and above any other technique or method that we have available to us today, increasing the proportion of people who are virally suppressed is clearly the number one way to prevent new HIV infections in the U.S. And it also benefits the health of people living with HIV. Now, in addition to the health benefits, to the public health benefits for preventing new transmissions, I think it's also important to acknowledge very briefly the mental health benefits and the benefits that it has to the self-image of people living with HIV. I've been living with HIV for over 20 years now, and I have to say, when these results came out, I felt a burden lifted off of my shoulders. That fear that somehow I might accidentally transmit HIV to my partner if a condom broke, it's a real, substantial concern that almost everybody living with HIV has with them each and every day. This changes how we look at ourselves, and I also believe that it's going to change how the public looks at us and shift the perception of stigma and attitudes towards people living with HIV in the U.S. So I'm truly excited to hear about the work that you've done, what's come out of it, and to see the things that you've learned in these projects be turned into action in other states, sustained in your state, and to look at the results as they come out for years to come. So thank you, everyone, for your hard work. Thank you for those of you who are on the call today to learn about what's come out of these projects. And I genuinely hope that you'll consider adopting these methods and using them in your own work. Thanks so much, everybody.
Thank you, sir. We'll now hear from Dr. Ellen Marie Whalen.
Thank you so much, and thank you for both the invitation to help welcome everyone to this webinar today. Thank you for Dr. Walensky for sharing your story and kind of reminding us what a critical breakthrough this is, that we finally have a way to measure viral load. Since the folks on the webinar aren't all from Medicaid, I just wanted to talk a little bit about why what we're doing in Medicaid at CMS isn't just coverage and services. Most of what we're doing as part of this Affinity Group is the measurement of the viral load suppression measure. When folks think of Medicaid, they often think about the coverage, the care that you get, and the fact that we're now providing coverage for services or medications. I think the good news about HIV is that if someone is covered by Medicaid, although the states run individual programs and can cover things differently state by state, coverage for HIV and AIDS and the medications is pretty much the same across states. So if someone is covered by Medicaid, they will likely be able to get the services to help them maintain the condition. That said, they are able to, but just because they have coverage doesn't always mean that they actually get the quality services that they're entitled to. And because of that, not just with HIV, but generally, back in 2015, CMS started to offer affinity groups for states that wanted to improve on the delivery and accessibility of certain services and certain conditions. And so we started to form these affinity groups on a number of different areas. And we selected areas that, first of all, the states thought were important. And second of all, areas where we had a measure in one of our core quality measure sets, and I'll just jump back to that in just a minute. But to give you a sense of what our affinity groups look like, we've done them on smoking cessation, diabetes prevention and management, antipsychotic drug use in children, and similar kinds of affinity groups. So we bring the states together, and critical, and especially in this work and in much of the work that we're doing, is we bring states together with their key partners in the states that help them look to what it is the state agencies can be doing to improve the delivery and accessibility of services that they're providing. As I mentioned, the focus is that the individual groups that we started were oftentimes related to a measure that we had in one of our core quality measure sets. And Medicaid has, and I won't get into, but if folks are interested, it's on our webpage. We have a set of adult core quality measures and child core quality measures where we ask states to voluntarily report on this set of measures. And one of the measures that we have in our adult core quality set is the viral load suppression measure. And so that has been the focus of what we're doing on our HIV Health Improvement Affinity Group, is helping states do a better job measuring the viral load suppression. And I'm sure, as most of you know better than I do, is that the way that we put that measure together, Medicaid doesn't have all the information that's required to be able to report that. We don't have a viral load value in our Medicaid claims data. So it's been critically important to work with the public health partners, because the viral load value is collected by public health and reported to CDC. So that has been the focus of the group. In 2016, we opened up to states the opportunity to participate in this group, and in fact we had 19 states identify that they were interested in this opportunity and wanted to participate through the full year. And I should say that these 19 states do account for almost 50% of all new diagnoses and almost 55% of folks living with HIV in the United States. States are encouraged to focus the efforts on establishing the data linkage necessary to report on the rates of viral load suppression for the Medicaid beneficiaries. And then once those linkages are established, use those data to try to improve care. Before the start of the Affinity Group, we only had 2 or 3 states reporting on the measure to CMS each year. And we're hoping that through these efforts, we're going to have a better sense of states being able to participate, and then we'll have more states that actually report on the state. I'll also note one of the differences with this affinity group versus our other ones, it's a really strong partnership across the federal government, as well as with individual organizations. So this affinity group is a really nice collaboration with CDC, with HRSA, obviously working also with the HHS Office of HIV and Infectious Policy, and also in partnership with NASHB. And it's the first affinity group that has a formal collaboration among our federal agencies. So just to close, we're really excited to be able to participate in this. We understand the importance of an affinity group like this working across multiple sectors. We are able to focus on tough issues because of the ability to partnership across HHS. And the HIV Health Improvement Affinity Group, along with all of our affinity groups, are certainly examples of how establishing this collective collaboration across Medicaid and public health sectors and other partners can continue to improve the quality of care and health outcomes for our Medicaid beneficiaries and improve the health of the general population. So again, thank you so much for allowing us to participate, and I also really look forward to hearing the examples and the work that folks are doing to move this important issue.
Thank you very much, ma'am. We'll now hear from Heather Hauk from the HIV/AIDS Bureau at HRSA.
Great, thank you. And I want to join my federal colleagues in welcoming all of you to the webinar today, and thank you for your participation. As you can tell already from my colleagues, this is a very exciting initiative for us as the federal partners and in partnership with NASHB. What I'm going to talk about this afternoon is a little bit more about the specific activities of the HIV Health Improvement Affinity Group and give some specific examples of the work that the state teams focused on during the past year, so that those of you who are on the webinar today that have not been involved in the state teams get a flavor for the work that's been going on during the past year. So to start the Affinity Group, back in October of 2016, the federal partners in collaboration with NASHB held a kickoff webinar that officially introduced the Affinity Group to the state teams and began the conversation with them about their performance improvement project plans and the expectations. We then had an opportunity, fortunately, in December of 2016 to have an in-person meeting that brought together the state teams from the Medicaid and the public health programs, the federal partners, and NASHB here in Washington, D.C. And at that in-person meeting, the state teams had an opportunity to hear from some very strategic thought leaders around topics like data being a foundation for action, performance improvement initiatives, initiating policy and systems changes, and managing cross-agency partners to improve systems of care for people living with HIV. It was a great opportunity for people to get out of their usual space, come together in one place, to hear some of these innovative thought leaders, and then equally importantly, there was time at that in-person meeting for the state teams to sit together to refine their action plans and to talk with each other across the state teams to begin some peer-to-peer technical assistance learning opportunities. So with those couple of months of lead-in activities, by January of 2017, each of the Affinity Group states had developed their performance improvement projects and had already started receiving some technical assistance on their specific state strategies to increase virologic suppression for people living with HIV. It's important for us to share that overwhelmingly across the HIV Health Improvement Affinity Group states, they identified data utilization as a primary focus of their performance improvement plans, as they really saw this as an opportunity to understand the services that people living with HIV are utilizing, their health outcomes, as a way to inform better policy and program improvements in their jurisdictions. So because of that somewhat common theme of data utilization, data collection, data utilization, data analysis across the 19 states, we grouped the states into 3 specific learning communities based on the focus of the plans. So the first learning community, and these are in no particular order, the first learning community was data linkage and the outcome learning community. And the improvement plans for the 6 states in this learning community focused on instituting or expanding current data sharing activities, as well as focusing on analyzing these data to identify targets for performance improvement. This group knew going in that this might mean interpreting or updating laws, regulations, and policies, as well as operational procedures to establish and accomplish these data linkages. The second learning community was titled Data Analysis and Utilization for Delivery System Improvements. So these states in this learning community focused on using data to identify quality improvement opportunities. The states planned to use aggregate or state-level data analyses to identify areas where they could make delivery system improvements. That might mean using existing Medicaid authorities to make new evidence-based services available to people living with HIV. It might have meant promoting integration of services funded by Medicaid and the Ryan White HIV/AIDS programs. It also might have meant encouraging systems that focused on interdisciplinary care teams. And in some cases, the state team was really looking at how to accelerate value-based purchasing through accountable care organizations. So that was the second learning community. The third learning community was focused on provider engagement and quality improvement. Members of this learning community focused on improving clinical outcomes and achieving greater viral suppression rates through increased efforts to engage healthcare providers to improve the quality of care of people living with HIV receiving services. The improvement plans in this group focused on developing mechanisms to better share data, again a common theme, between their state's public health and Medicaid organizations, And these improved information sharing mechanisms will help states to identify people who have been either out of care or unable to access care and re-engage them into care in order to get them back onto HIV medications, which again helps people achieve sustained viral suppression. So those were the three main learning communities throughout the past year. In addition to the activities I've already mentioned, each of those three learning communities had another series of activities that included 8 Affinity-wide, so everybody was engaged, webinars with an average attendance of over 60 participants. We provided information on topics such as developing problem statements and performance improvement plans, data transfer and use, data visualization, and creating the technical architecture to facilitate data use and data analysis. In addition to the Affinity Group-wide webinars, there were bi-monthly learning community calls, and these were really focused on providing the state teams and the groups with an opportunity to discuss the current status of their state plans, to share challenges, to talk about lessons learned, and to also talk about the successes they were having among their state teams. They also received monthly learning community newsletters. There were also 2 blog posts that have been published so far. And then, as I mentioned at the very beginning, there were state-specific technical assistance opportunities to provide, which were provided to a variety of state teams, as well as provided via an intranet type of website that was accessible to the state teams. And then last but not least, we were very fortunate again to have an in-person meeting in Portland, Oregon as part of the NASHB annual conference in October 2017, just a few months ago, where all of the state teams were able to participate and to share again in a large group setting lessons learned, challenges, opportunities for future work, and ongoing technical assistance needs. So that was a lot to share, but we really wanted to share all of this information with you because we really do think that the 19 states that have been participating in the HIV Health Improvement and Affinity Group have laid an impressive foundation for moving this type of public health Medicaid partnership work along with this very specific focus on improving viral suppression among people living with HIV in the country. The activities that they have done and the activities that other states could learn from and implement based on this foundation will, we believe, as both Rich and Ellen Marie have already indicated, will improve health outcomes for people living with HIV in the country, which will reduce new HIV transmissions and move us closer to ending the HIV epidemic in the United States. So with that, I'm now going to turn the webinar back over to Commander Davies to introduce our next speaker.
Thank you very much, ma'am. And lastly, but not least, we will hear from Dr. Janet Hikert from CDC.
Thank you. Thank you, everyone, for the opportunity to present preliminary results from the Affinity Group evaluation. The purpose of the evaluation was to assess the processes and short-term outcomes associated with participating in the Affinity Group. We were also interested in documenting lessons learned, including successes, challenges, and promising practices. Data were collected in September and October of this year via a web-based survey and telephone interviews of state health department and Medicaid agency staff participating in the Affinity Group. We also reviewed documents including slide sets and call notes. This is the first CMS Affinity Group to include an evaluation component as part of the process. So now I will discuss some of the preliminary results. Participation in the Affinity Group created opportunities to establish and strengthen partnerships between the two agencies to achieve their performance plan objectives. For example, of the states without an existing mechanism to share Medicaid data with public health, 2/3 were able to establish a data use agreement. Although the other 1/3 were unable to do so in the 1-year time period, participants were encouraged by the open channels of communication between the two agencies and were optimistic that an agreement could be finalized. as noted by one public health agency. I know that these things take time and that persistence is what is rewarded. I think we have a good way forward. If things fall apart with the agreement, I know who to contact nationally for technical assistance. What was most helpful is demonstrating that data sharing is happening in many states and is an expectation of CMS now. States that established or had an existing data use agreement initiated or streamlined matching of Medicaid claims data and public health HIV surveillance data, and in some instances, data from Ryan White. Most often, it was the public health HIV program gaining access to the Medicaid claims data, but a few states were working toward bidirectional data exchange. About half of the states with data matching capabilities generated an HIV care continuum for specific groups or populations. For example, one state used elements of the care continuum to produce customized fact sheets for each Medicaid managed care plan that also displayed viral suppression by race, sex, and geography. As noted by one public health agency, we plan to conduct further analyses examining care continuum outcomes for Medicaid enrollees seen at Ryan White clinics compared to all others, and potentially by provider where numbers are sufficient. A few participants mentioned implementation of quality improvement procedures and policy changes as examples of successes. However, additional analysis of the data is needed to better understand the nature and the extent of these outcomes. It is noteworthy that all states remained an active participant in the Affinity Group during the one-year period. Furthermore, almost all Affinity Group participants believe that sustainability of their accomplishments was somewhat or very likely. In fact, 2/3 responded very likely. As noted by one Medicaid participant, I think this relationship is going to be ongoing long past the closure of this particular initiative. So how did the Affinity Group process contribute to the outcomes I've described? First, the Affinity Group provided a structure for participants to meet regularly, to learn what each agency brought to the table, and to identify promising practices from other states. Second, prioritization of this effort by federal partners gave it credibility and helped states justify spending the time and resources needed to develop and implement their performance improvement plans. As noted by one Medicaid agency, the Affinity Group process got us engaging in these conversations at a level we might not have prioritized without it. So to kind of summarize what I've just said, initial results from the evaluation indicated that participation in the Affinity Group contributed to increased knowledge and collaboration between the two agencies, and this collaboration will continue past the project's first year. NASHB is packaging this work so that other states can take advantage of the outcomes of this process, including lessons learned and best practices. Thank you for letting me speak this afternoon.
Thank you very much, ma'am. So as you have heard, this Affinity Group consisted of 19 states, and these states included Alaska, California, Connecticut, Georgia, Illinois, Iowa, Louisiana, Maryland, Massachusetts, Michigan, Mississippi, Nevada, New Hampshire, New York, North Carolina, Rhode Island, Virginia, Washington, and Wisconsin. So a very diverse group spread out throughout the country. And what we'd like to do now is to hear from 2 of those states for their thoughts and lessons learned. I will pass it off to Susan Jones from Alaska. Susan Jones is the HIV/STD Program Manager for the state of Alaska. She has worked for the Section of Epidemiology HIV/STD program since 1995 with the CDC STD-related Infertility Prevention Project, STD program, and HIV care services under the Ryan White Care Act. She has also been a public health nurse in Interior and Arctic Alaska and taught at the University of Alaska School of Nursing in Fairbanks and Anchorage. She received her graduate degree in nursing from Montana State University in Bozeman, Montana. Ma'am?
Hi, this is Susan. Thank you for inviting Alaska to present our work in the Affinity Group. We were very excited to participate, and I think was the first state to sign up. So I'm from the section of epidemiology, as the introduction said, and then I worked with Margaret Brody, who is the director for healthcare services and Medicaid. If we could have the next slide, please. So first of all, I just want you to know the characteristics of Alaska. We think we're different. This slide says Alaska versus the lower 48. The lower 48 is the continental U.S. That's how we refer to the rest of you. But right now I'm going to bring you to Alaska. And I want you just to see the size of the state. If we were to superimpose the state onto the lower 48, we would see that we would extend to the Pacific and the Atlantic, and from the northern Minnesota down through Texas. So it's a very large state. Next slide, please. So some of the characteristics of Alaska. First, I just let you know that it's at 11:04 a.m. in Alaska, and the sun just came up about 20 minutes ago. So we have bright sunshine. We have a very diverse state in that there are parts of the state where it's really hot in the summer and parts of the state where it's very cold. So some of these characteristics here just give you a feel of what Alaska's like. I think that there's a couple of characteristics in Alaska that are worth noting. Number one, we don't have county health departments. So the state health department kind of acts as what you would do for a county health department, but we do it for the entire state. We have a very high cost of living, we have very high travel expenses, and we have very few roads. So most of the state is traversed by air. Also, you might not think of this, but Anchorage has one of the most diverse neighborhoods in the country. The school district in Anchorage speaks over 100 languages. We have temperature ranges from above 100 degrees to minus 80 below. And I've been in temperatures of 70 below zero, and that's very cold. The next slide, please. So I'd just like to give you a little bit of background about HIV in Alaska. We're considered a low incidence state, and we really have only between 20 and 50 newly reported cases a year, and about the same number of cases that are reported that were diagnosed elsewhere, but those folks have moved to Alaska. And I think one of my missions is to let you all know that even a low incidence state can be very innovative and can do things that are worthwhile and may be replicated in other states. One of the reasons that we could enter into this affinity group was our work that we've done through the CDC HIV Prevention Grant 121201 with Linkage to Care. We established a Linkage to Care system in Alaska in 2012. And because of that established system, we were able to have our HIV surveillance database very cleaned up and very tight and use it for Linkage to Care. The Linkage to Care has two components. One is for folks that are newly diagnosed to make sure that they enter medical care and stay in medical care. And the other component is those individuals who were previously diagnosed and have been lost to care to help them to re-enter care. And we've been very successful in doing that. The other background component that helped us with joining the Affinity Group was in 2015, Alaska expanded the Medicaid program. So that also had more individuals with HIV now not being served under Ryan White, but being served under Medicaid. When the Linkage to Care program under the HIV Prevention Grant was completed, we continued Linkage to Care services under the Ryan White Part B supplemental funds and under the Early Intervention Services. So we've been able to continue Linkage to Care under those funds. And if I could have the next slide, please. So our goal for the Affinity Group, number one, was to meet the Medicaid director, who I hadn't met before. But we really wanted to make sure that individuals with HIV and infection who are enrolled in Medicaid will have a reduced viral load and be less likely to transmit the virus. And with the U equals U initiative, we're so excited about that and wanted to make sure that individuals are in care and do attain viral suppression and being maintained in care. So that was the goal in contacting the Medicaid director and being part of the Affinity Group. Next slide, please. So this is pictures of us here in Alaska. We just want you to know that we look like normal folk. The Medicaid director, we met in August of 2016. We agreed upon our goals, which was to help individuals with HIV who were enrolled in Medicaid to stay in care. And we needed to establish a way to share data. I think that was our biggest challenge. And next slide, please. So the combined goals were to improve the health of Alaskans with HIV and to prevent transmission of HIV by helping folks obtain viral suppression. One of the outcomes is Alaskans with HIV who are enrolled in Medicaid are actively enrolled in HIV medical care. The milestone activities that we had delineated were that Medicaid providers serving patients with HIV infection would know about the Linkage to Care program, know how to access the program, which is run out of the state office here and is based on surveillance data. And the HIV program would identify any Medicaid enrollees who have HIV and are unknown in our HIV surveillance data system. And so the collaboration that we established was to share data between Medicaid and HIV care services. I think that one of the things that we wanted to be sure is that if there was somebody enrolled in Medicaid that had HIV, we knew about them at the state office. And if they didn't, we could get them linked into care. The next slide, please. So from our goal, as Heather Houck described, we were in the group that is provider engagement, quality improvement community. And that included Alaska, Connecticut, Michigan, Mississippi, Nevada, New Hampshire, and Virginia. I'm not sure how easy it was to compare all of our goals, but one of the things that we definitely had in common was to have a data sharing agreement and to make sure people were virally suppressed. So the next slide, please. So in November of 2016, we were able to establish a data confidentiality agreement with Medicaid. And Medicaid, the advantages of being able to do this so quickly was that Medicaid had other data agreements with other divisions within the Department of Health and Social Services. We also had the same lawyer between the section of epidemiology and Medicaid, and that really facilitated the process. I understand that some states, their roadblock was the lawyer's disagreement on the data sharing agreement. The other big help for us was seeing what other states had done. And we asked for Louisiana's data sharing agreement and looked at that when we were establishing the data sharing agreement. So how this worked was the data sharing agreement that Medicaid had with other divisions was shared with us, and then the Medicaid director and I tweaked it so it would have the components that we needed for this program. The major components are listed over on the right-hand side of the slide. So there was a protection of privacy of the information, that we would protect the Medicaid information, and that the data would only be used for the project, but we kind of expanded what it would be used for, so it would include care coordination, linkage to care, that L2C is linkage to care, disease control, so if there were folks that we didn't know about, we could do partner notification and help people get enrolled into medical care. quality assurance, and improved performance. That is making sure that individuals received viral suppression. So we agreed with Medicaid, the Department of Healthcare Services, that we would not release or transmit the data for anything without Medicaid's approval. We also got the Department of Public Health acknowledged the criminal and civil penalties under federal law should we release the data. And one of the clarifications that we did when we were developing the data care agreement was that the Department of Public Health could contact persons who are in the Medicaid database that maybe aren't in our surveillance database. So those were the components of the confidentiality agreement. And it didn't take long to get that established. We just kind of tweaked it, sent it back and forth with the lawyer a couple of times, and it was signed and done in November. Next slide, please. So this is a picture of Denali, previously known as Mount McKinley. So I think that that just represents our first step was looking at the data. And you can see, because we're a low incidence state, Medicaid staff pulled Medicaid claims that were related to HIV. And they were able to identify 295 individuals. And we looked at those folks in our database, and they were all in our EHARS or HIV surveillance database, except for one person. We asked Medicaid at that point if we could actually have direct access to their claims data, and that's the Denali Mountain over there. And it was agreed upon, and so we did get access to the Medicaid claims data. And so our IT person contacted the Medicaid IT person, and we started doing the data extraction, which is the next slide. So we had discussions with the Medicaid staff, and I have to say that Margaret Brody and I were more like the conductors of the orchestra, but the real people that played the music were the staff that worked together on this. We looked at doing data extraction in two ways. Looking at the ICD-10 HIV claims data for a medical care visit, and then we also looked at the pharmacy claim for antiretroviral medications that are just primarily used for HIV. That data was sorted in three ways. We looked at those individuals that only had a medical claim but no pharmacy claim. We looked at individuals that only had a pharmacy claim but no medical claim. And then we looked at individuals that had both. So I think that this was the first biggest task and challenge for us, was the complexity of the Medicaid database. It was very complex, and we had to learn how to use it. There were several false starts in getting incomplete data results. And the Medicaid staff were really the stars in working with our IT person to navigate the claims data system. We were able to extract a sample list of patients, and then each patient often had up to 100 claims transactions or more. So sorting through all that was a real challenge. But we did sort through it, and then we did a comparison with our HIV surveillance or EHARS database. We also then did some follow-up with providers and required verification of HIV status. So the next slide, please. Now, I just kind of presented that to you in a quick synopsis of what we did, but it really took quite a long time, because our review with the EHARS data was not an electronic match, it was a manual match, where our staff went in and looked at the Medicaid claims data and then looked at the EHARS data and tried to figure out who we had in there and whether we had viral suppression or not of those individuals that had a claims data. So this is our continuum of care for individuals that had a Medicaid claim from April 2016 through March 31st, 2017. That date corresponds with our Ryan White CARE Act grant year, and we also confirmed with Medicaid that that data would work for their reporting of their level of viral suppression. And what we found, we only looked at 405 records. That's one of the nice things about being a low incidence state. But what we found were 405 records. Of those, 317 we classified as HIV positive, and 88 were not confirmed as positive. Of those, in the second column, you'll see that of those 317, 316 were in our HIV surveillance database, and one person was not. The person that was not in the surveillance database was fairly newly diagnosed, and we would have captured her eventually, but we didn't have her at the time. Of those 88 individuals that were not confirmed as positive, this is how we distributed them. One is still under investigation. We can't find the person. 18 were confirmed negative. One was unable to investigate. And 68 were assumed to be negative. They seem to be on the list for a variety of reasons. By looking at antiretroviral medications, we were able to see that some of those individuals were on PEP or PrEP, depending on the medications. They were not HIV positive. They were taking the medication to prevent HIV. Or they were on antiretroviral medications for another condition. Some of them tested for HIV but were negative, but were listed in the claims database. Some were recorded as false positive tests, and they were really HIV negative. And then there were several that were possible billing errors. And I think that one of the things that we found is some of those billing errors were from emergency room visits when the individual would self-report that they were HIV positive. We actually did some record searches on those individuals and found that they never had a positive test, and actually contacted one of the individuals, and after seeing that he had a negative test, told him he wasn't HIV positive. So that was quite a finding. And it was also interesting to Medicaid that there were some billing errors. The next slide, please. Oh, let me go back to that slide one more time, because I just need to tell you that you can see on that slide that 78% of those records that we looked at were confirmed HIV cases. And of those HIV cases, 97% of those were engaged in care. And of those that were engaged in care, 85% were virally suppressed, which I think is pretty significant and actually reflects our continuum of care that we have for our other HIV patients. Next slide. So just findings review. It was a manual review of Medicaid data against our HIV surveillance database, EHARS. We looked at whether the person was in EHARS or not, whether the person was a known HIV status, the person with a negative HIV status or assumed negative, and then erroneous data. That was kind of a summary of the findings. Next slide. So I think that one of the big characteristics we found is that if the person had HIV and was enrolled in Medicaid but didn't have a claim during the period that we looked at, we might have missed them, which kind of leads us into some of the future activities that we're going to look at. Next slide, please. So some of the challenges, supports, and ahas. The challenges, of course, for a low incidence state is we have such a small staff in the Department of Public Health. And then the challenges for the Medicaid side is that they have a very complicated system, and their staff wears many hats and have many things that they have to do. The other challenge for us was the complicated Medicaid database and the challenge of having to do this as a manual review. The supports are that our HIV program is really an integrated program. The HIV surveillance officer is also one of the linkage to care people and does some of the DIS for HIV. We also have a strong linkage to care system. And then the support was the Medicaid goals are consistent with the HIV STD program goals, and Medicaid folks are very easy to work with. So that was a big support. The AHAs was looking at the antiretroviral meds and being able to find PrEP and PEP being prescribed for individuals. The other AHA was looking at hospitals and reporting the B20 codes and maybe using those in the future as a quick to linkage to care. The other was the hospital's ER actions when a person self-reports that they're positive for HIV, but there's never an indication through the different ER visits that they received any HIV services. And then the other AHA was the errors in the billing. So the next slide. So this picture on the slide to the right is the return of a whale jawbone into the sea from Arctic hunters that hunt for whales, the Alaska Natives that hunt for whales. And the tradition is that when you're finished with the task of butchering the whale, you put the jawbone back into the sea to guarantee future whales will swim up and give themselves to you to be eaten. So the idea here is that we finish the task, but we still have things to go. And one of the next steps that we want to do is we'd like to do an electronic review instead of doing a manual review of the data match. We need to be able to search the Medicaid database by name for those individuals that we know from our surveillance database that are out of care and may not have a claims data. We're working on trying to produce a list from our surveillance database that has the viral load for patients. We'd like to continue to do this annually. Not only do we want to make sure that we have individuals that are on Medicaid in our surveillance database, but to make sure we're not missing anyone, and to give Medicaid back the information on this viral suppression. So the next slide. So this is just a little visual relief from all the data, and to let you know that I'll be available for questions should you have them. And that's the end of my presentation. Thank you.
Thank you very much, Susan. Our next presenter is Brad Wheeler. Brad is the HIV care epidemiologist for the state of North Carolina. He manages operations of the North Carolina Engagement and Care Database for HIV Outreach, a meta system that regularly captures and reconciles HIV care marker data from HIV surveillance, Ryan White, and Medicaid sources, enabling creation of out-of-care lists. He is responsible for ad hoc HIV care analyses, linking HIV care data, and creating performance-measured dashboards for the state's Ryan White programs. He received training in epidemiology and health informatics at the University of North Carolina at Chapel Hill, an MPH from East Carolina University, and a Bachelor of Musical Arts from Penn State University. Brad?
Thank you very much. First of all, it's wonderful to be presenting some of our work from North Carolina after 1 year of our membership in the HIV Health Improvement Affinity Group. I'd also like to give some quick acknowledgments to our partners, Community Care of North Carolina, who I work with, as well as our champions over at North Carolina Division of Medical Assistance, who manage our Medicaid program. So, I noticed the title of this presentation was Improving Viral Load Suppression, and I like to think of that as our long journey. And it may not actually be a very long road if we are all working together, but it is definitely made up of steps of work that people in the community do. Our work in public health, our HIV surveillance group has been working on better measurement of HIV care markers. Our Ryan White programs have already been working on improving quality and we're happy to be working with our Medicaid program, which provides needed services for so many people. So our work here really is a natural collaboration, and I'd like to tell you a little bit more about what we did. So first, a little bit of background on North Carolina. North Carolina is a pretty diverse state. We're pretty large in terms of population, top quartile anyway. We're the 9th largest state by population, and we're also quickly growing in terms of our population. Some of our larger metropolitan areas are growing very quickly. However, we retain substantial rurality. We have lots of quiet space, beautiful mountains, and we're also known for 2 different styles of barbecue. So come check us out. As it relates to HIV in North Carolina, we are considered to be a high incidence state, like many of our peers in the South. We have an incidence rate of approximately 16 cases per 100,000. That's been leveling off, but that translates to approximately 1,400 infections reported in 2016 and a prevalence of about 34,000 cases. So we have a high burden in the state. When we first started to hear about the Health Improvement Affinity Group, we were already working on a HIV care outcomes platform that helped to better manage our data internally within public health. We had a system developed called NC Echo, which is the Engagement in Care database for HIV outreach. And what that really did was to help de-silo some of the data that's stored in HIV surveillance, in our CareWare system, which is used for our Ryan White partners. And we also developed a relationship with North Carolina Medicaid to get a list of people who had HIV care indicators, such as antiretroviral drugs or labs or diagnosis codes. So we were very excited to hear that, this was an opportunity to better partner with Medicaid. We plan to use this data system to be a general purpose outcomes platform for reporting care measures such as those that are on the HIV care continuum. And we'd already been using this for some of our programs, such as our AIDS Drug Assistance Program, known as HMAP, our HOPLA program, and for our Part B Ryan White programs. So when we approached our partners, they were very interested in partnering with us, and we got to work on developing a work plan. We were kind of pushed toward the data linkage and outcomes learning community because we were formalizing our data exchange relationship with our partners, and then kind of learning how to use NC Echo to kind of integrate with an external partner. So what we did, we first sat down and thought about what definitions were important from a claims perspective in order to kind of identify clients in Medicaid who might be HIV positive. Then we also worked on developing a 3-way data use agreement, which is much more complex than a 2-way data use agreement. And then we were going to perform a match to our HIV surveillance and care data and look at the set of people that matched. And then finally, once we had this, we would generate a full continuum of care and look at that and think about what that means in terms of performance measurement, in terms of situational awareness, and thinking forward to potential care interventions. So our data use agreement between CCNC, Division of Medical Assistance, and DPH was formed. It borrowed heavily from another request that we had between us and DMA for NC Echo. The specifications for this were essentially a 1-year window of time. So we chose calendar year 2016, people with claims during that period. And we asked CCNC to provide us a list of people that had information on their identifiers so that we could match. So for instance, last name, first name, Social Security number, and date of birth. And then we also asked CCNC to provide us a count of claims during that period that met one of several buckets of claims. One of those buckets was diagnosis codes, another was HIV beds, and the other one was HIV lab procedures. And then finally, CCNC gave us some information on whether the client was enrolled in a managed care plan, which is something that CCNC provides as a value-added service. So this is the technical stuff here. We wanted to make sure that we were identifying HIV in a valid way. So we used a definition that included diagnosis codes listed here as B20, Z21, and then a couple of other ones, B9735 and O987, that might pick up residual HIV comorbidities. We looked at HIV lab markers, so these would be billed procedures for a CD4 test or a viral load. And we also sent a huge list of antiretroviral drugs. Those are listed in NDC format, so it essentially is like a barcode for each type of medicine. And I'll talk a little bit more about how these performed. But essentially what we asked here was that anybody who had one of these markers go on this list for a match to HIV surveillance. So what we did in order to make this linkage happen, we used a linkage system called probabilistic linkage, and that just uses all of the data that we can throw into this match to generate what we think is the best guess for a record in one data set against the other one. And if the data quality is good and we're looking at the same people, the probabilistic linkage will perform very well. So what we did here was we looked at Social Security number, birth date, last name, first name, sex, race, and ethnicity, as reported in Medicaid and as reported in HIV surveillance. And that performed remarkably well. 83% of the people that were in that original list of clients matched to our HIV surveillance database. And when we looked at who those people were in terms of their demographic groups, they looked very similar to our state distributions of sex, race, age, and we were able to then generate a continuum based on that set. And then we also had a group of people that did not match to HIV surveillance. And I'll talk a little bit more about what we did, but that provides us some information to investigate and ask follow-up questions on. So we did look at this. We looked at how well the match performed by the type of utilization. And we found that HIV diagnosis code was the most predictive factor for matching to surveillance. Sensitivity of 98%, so we matched 98% of people across these two. The odds of matching by diagnosis code were 74 times if you had one or more diagnosis codes versus not. We also found that there were people that had diagnosis codes that did not match, and so we were able to look a little bit further in depth. Similarly, we looked at the antiretroviral drugs, and it had a very good specificity of 82%, meaning that if you didn't have an antiretroviral drug, you were more likely not to match. But we learned later when looking at that list of drugs, we didn't include the most recent treatments, and we have reason to believe that that's a really big predictor of if you're going to match on this criteria. And then finally, we looked at lab procedures, CD4 tests, and viral loads, and they performed kind of the worst. And I think that has to do with the fact that they're not necessarily specific to HIV, particularly the CD4 test. It's a general marker of immune status, and by asking CCNC to report out everybody with a CD4 test kind of expanded the data set. Then we looked at this by demographic factors, and this was really the most notable difference here, and we learned the most from, I think, this graphic. When we looked at the age distribution of people who matched versus those who didn't, it looked like the non-matches tended to be younger, and so that was a bit of a curiosity. So we looked at the components there, and we found that approximately 70% of the infants, children, and youth only had a lab procedure, and it was more often than not a CD4 test. So CD4 tests are not very specific, and these people were potentially erroneously in our list. So that was one of our aha moments, learning about these definitions. The other aha moment that we had really came down to reporting out the continuum and thinking about what it means to communicate population-level indicators and thinking of this across organizations. The HIV care continuum model has a viral load suppression measurement embedded in it. It's the last bar. It is based upon somebody's last test in the measurement year. If it's less than 200 copies, they're virally suppressed. The denominator for this is people living with diagnosed HIV who live in the jurisdiction. So that is everybody who is alive in North Carolina. That would be about 34,000 people. Compare that with NQF 2082, which is the quality measure developed by HRSA. I heard a whole lot about NQF 2082 during this affinity group. That's similar in the numerator in that the last test criteria is the same, but the denominator here is people with one or more lab visits in the measurement year. So that's potentially many fewer people. In North Carolina, about 23,000 people had a care visit in the measurement year. So that is a really important difference here. And I think I can show this graphically here. We have our North Carolina care continuum from 2016, and the difference really is in the first and second bars here. We have the 34,000 people represented in the first bar, diagnosed, reported, and still believed to be living in North Carolina. And then we have in the second bar the subset of those people who had a care visit in the measurement year. And so we're thinking about that last bar and we just need to think about the denominator that we're using. So translating this into 2082, we would rebase the denominator, at least one care visit to be the measurement population, and we would look at the subset of those who are virally suppressed. And that performs a little bit better. And the reason why I'm discussing this is because once we start reporting out performance and comparing it to other populations like the Ryan White Part B population or the population of people who receive HALPA services, we really need to think carefully about who's in the measurement set. I'll talk just a little bit more about it. The difference between those first and second bars that I had mentioned is essentially our out-of-care list, and that's something I've been working on. And I'd just like to say that public health has capacity to look at this group with more clarity. We have a field services program that receives lists of these clients and is able to figure out the status of these people. But these are essentially the people that are not coming to the clinic for one reason or another. We may have people who just extend their intervals, so they'll come in every 13 months. And if you ask them if they're in care, they'll say yes, that they're in care. Then it's possible we also have people who have moved out of state, and our surveillance system has not yet picked up on that. And so they're still counted as living in the state. And then finally, we have, going back very far in our surveillance data, we have people with just no trail. And you have to wonder if for some reason they are erroneously reported as alive and they're actually deceased. So I think this is core functionality that we have in public health that will help think about the population as a whole, while we're also looking at quality within the clinical subgroups and within the Medicaid population. So as far as it relates to our work in the Affinity Group, we're going to keep going at this. Our DUA specifies that we have another round of data coming, and I think we're going to tweak the methodology a little bit to kind of separate out some of the codes that we think might be less predictive. We were able to learn a little bit in that first match, and I think we can just tweak it and come up with a better match. And then we're thinking about dashboard measures that are helpful for policymakers, and we're interested in looking at this from many dimensions. Our branch has a plan to eliminate disparities, so we think this works with that. Our Medicaid Managed Care Agency wants to look at providers of medical homes for clients, and they want to measure effectiveness. And we think that we can build on this work and deliver quality and work our way toward universal viral suppression. Thank you very much.
Great. Thank you so much, Brad and Susan, for your presentation. We did get a couple questions throughout the course of the presentation, and I will toss the first one to you, Brad. For North Carolina, how did you find the company to develop this database, and how did you get everyone to agree to share data?
That's a very good question. So I think I ran through that slide very quickly, but this was carefully planned out work. We were a recipient of a HRSA SPINS grant to look at system linkages, and that grant included many things, but one project that we had long been interested in was a data warehouse that helped integrate HIV care data. North Carolina is a little unique in that our Ryan White program and our HIV surveillance program and our ADAP program, they're all housed within one branch. So we had strong affinity within the branch to combine this data. We wanted a platform to make that happen, so it was much more of a technical issue. As far as Medicaid, I think we had conceptually gotten support from a long time ago. We'd been receiving data from them since at least 2004 for some of our HRSA analyses. Unmet need is the one that comes to mind. So the internals of getting people together to agree to exchange data, I think were a little easier for us. I know other states had some significant barriers.
Thank you so much, Brad. Is Dr. Whalen still on the line? Okay, thank you. So the last two questions are actually directed towards CMS and would be in Dr. Whalen's wheelhouse to answer. So what we will do is we'll take these two questions and the people that have posed them and pass them along to Dr. Whalen. And then when we post the webinar on the NASHB website, we'll make sure we also include the answers to these two questions so that everybody has access to that. So I'm going to give a couple of minutes for seconds for any other questions.
Commander Davies, this is Susan Jones. I don't have a question but a comment.
Go ahead, Susan.
Yeah, in Alaska, we have CD4 and viral loads reportable to the HIV surveillance office. So that is one of the other supports that we have. So we have that recorded in the surveillance database, and I think that is worth noting. Thank you.
Thank you, Susan. I am not seeing anybody feverishly typing. So I guess we will move on.
Kat, this is Rachel. We did have one other question come in on clinical pharmacists.
Okay, hold on. Can you read that question for me?
Sure. So one of our participants asked, did either group or either state, Alaska and North Carolina, include a clinical pharmacist?
So Brad or Susan, do you know if you had a clinical pharmacist in your group?
This is Susan. We didn't have a clinical pharmacist, but we did have the pharmacist from Medicaid help us with the data extraction on antiretroviral medications that were in the Medicaid claims data. So she assisted us in making sure that we extracted the right data.
And I'd also like to jump in. From North Carolina, we did not include a clinical pharmacist in our team, but I will say that understanding the drugs is a very important component if you're going to be looking at them. The one thing I pointed out was that the treatments tend to only get more voluminous. In other words, there are more antiretrovirals now than there were a year ago. And if you are not picking up on that, you may be losing the group of people that switches. And in North Carolina, there are a lot of people that switch to the newest treatments. So I think that's good advice.
Thank you both. We have another question from New York. This is Health First from New York City. Has anyone utilized peers to engage membership? What has been your experience? So Susan, I'll go to you first and then to Brad.
Membership in the Affinity Group, membership in what? I don't fully understand the question.
Susan, we would assume that the person is referring to peers assisting Medicaid beneficiaries.
Mm-hmm. Oh, I see. You know, our first task in Alaska was just to to look at the individuals that had an HIV claim of some sort in Medicaid and make sure that they were in care or we could get them into care. So I guess if you have a hierarchy of need and data, we're at the ground floor, and we did not include any peers.
Thank you, Susan. Brad, anything to add?
Yes. Really, North Carolina, we have consumer representation mostly in our Ryan White program. We have a regional quality council that has consumer representatives, and our HIPCAC, which is a consumer advisory council. I think it relates, our work on quality improvement involves consumers, and we actually, I can get into this a little later, we have a lot of consumer-focused work that we're looking into. So, but our Ryan White group is very, very heavily consumer-focused.
Great. Thank you very much. And I don't see any other questions other than the ones that we are about to answer. So we have some forthcoming resources that will be coming out throughout the remainder of the month, and they'll be housed on the NASHB website. There will be a blog specific to the Affinity Group entitled States Use Data to Improve the Health of People Living with HIV. There will also be 2 issue briefs, one entitled Prioritizing Care, Partnering with Providers and Managed Care Organizations to Improve Health Outcomes of People Living with HIV, and 2, Utilizing Medicaid and State Health Department Data to Improve Health Outcomes of People Living with HIV. And finally, as you heard earlier, one of the resources that was critical during this Affinity Group process was a website in which we stored a lot of information. This website is now being reworked and will be released as a toolkit for public use. So please keep a lookout for information on this and the other resources in the NASHB newsletter and information from your project officer. Also, the recording of today's webinar and slides will be available on the NASHB website within the next week. So you'll have the slides available to you. And as I said earlier, we'll definitely make sure that we get the answer to those last 2 questions when we post the website or the webinar. Thank you so much for taking this time and sharing your afternoon with us to learn more about the HIV Health Improvement Affinity Group. It has been a pleasure working with the states, and we hope that you will be looking forward to more information and joining in on the lessons learned. Thank you.